Hi, everyone. This is so great to be up here and see you all. This year's Komodo Week theme is Mission in Action, and nowhere is our mission more represented than in our work with our patient advocacy organization partners. They do so much to drive education and awareness, they fund critical research, and they improve standards of care for patients. They do policy work, there's so much that they do. So today I'm really honored to be joined by our three wonderful Mission in Action panelists, some of whom you may remember from the video that we just saw, or the video on, I believe it was Monday. And they all exemplify the mission, leadership, and passion it takes to reduce the burden of disease. Each of them is doing incredible work, and I can't wait for you to hear their stories. The opportunities they see for the industry to collaborate more effectively, and where they see data and technology playing a role to drive better outcomes. So I'm thrilled to introduce to our Komodo family these panelists. Amy Wood, I believe you can come out. So Amy is the executive director and founder of the Raymond A. Wood Foundation, where she serves as a patient advocate and works tirelessly to empower hypothalamic pituitary brain tumor survivors for improved quality of life with access to education, technology, and emerging therapeutics. Luciana Peixoto. So Luciana serves on the Parents Advisory Board of the Systemic Juvenile Idiopathic Arthritis Foundation, SJIA, and she supports patients of SJIA patients in finding treatment options for their children, as well as research into the incidence and impact of this rare disease. And finally, Sanaz Eftekhari from the Allergy and Asthma Foundation. So Sanaz is the Chief of Business Development and VP of Research at the Asthma and Allergy Foundation of America, AFA, which includes leading partnerships to encourage patient-centered research and collaborating on AFA-led research initiatives around the needs of patients and their families. So I know so many of us here at Komodo come to this work because we have a personal experience with the healthcare system, for ourselves, for our loved ones, for our friends. And most of us have seen firsthand the power of that healthcare system. And unfortunately, a lot of us have also seen opportunities to improve the healthcare ecosystem, whether that's earlier diagnoses, access to understandable patient-facing education about a specific condition, more readily available clinical trials, or simply more therapeutic options. And so all of you folks on stage are doing that work to help patients find better care and really push for more treatment, so thank you. We're excited to jump in and hear your perspectives. So with that mission-first approach in mind, we'll kick things off by hearing about your story and how you came into this work. So Amy, we'll start with you. What lit that spark for you to get involved in this work, and what helps you keep going? What makes you keep going? We'll start with you, and then we'll go down the line.
Well, first of all, I just wanted to say thank you for having us here. It's really such a great opportunity. This tool has been amazing to use this past year for our organization, so it's nice to be here among its creators, so thank you. I think what drives me is simple love for my son, Alex. Alex was diagnosed with a craniopharyngioma brain tumor at age 4. Up until the day of his diagnosis, he was leading a typical 4-year-old life until one day we noticed something was going on with his left eye. As that day progressed, we ended up in the emergency department of Johns Hopkins, where they told us he had a mass in the middle of his brain. That night when they told me this, I vowed that this would not happen in vain, and that, you know, if there's something good to come of this. And every day since, he's now 12, he has endured the aftermath of this tumor in his health conditions. He has 4 rare medical conditions as a result of tumor treatment, and in his cognitive capabilities. And I see this in him. I see where we have been craving support that just doesn't exist, and that there's families out there less resourced than ours that, you know, are also in dire need of support, and that's what drives me every day.
Thank you. And Luciana, how about you?
Well, thank you to be here. I'm Luciana. I'm from Brazil. I have 2 kids, not kids anymore, 20 and 23. And this journey started 22 years ago when my son was diagnosed with diabetes type 1, and he was 1 year old. Then, life is good. And my daughter was diagnosed with systemic juvenile idiopathic arthritis, so this is SJIA. And what do I do when I have a challenge? Well, I'm going to learn, and I'm going to understand these diseases and try to give the best care that I can. But SJIA is particularly very challenging because sometimes you don't have a medication that works. So this is how I started, because I have a science background. I am an engineer, and now I'm working with the health system and advocating. And my passion, well, first, what drives me was the disease of my kids, and I wanted them to be well. And now that I'm in a good place, so I came back to help the foundation and to help other children. So seeing the other children like do a lot of things, and you cannot even imagine being at a hospital and doing a lot of things that they just want to play. They just want to play, and that's amazing. So that's how I started to work to take care of these kids.
Thank you. And Sanaz, how about you?
Well, I'm in awe of these amazing moms. I come at it from a little bit of a different perspective. I don't have a personal story to asthma or allergies, but what started 15 years ago as a 1-year internship during college turned into a career that I never expected in patient advocacy. And it's just because after that 1 year of internship, I just kept hearing more of the patient stories similar to what these moms here are talking about. And it just made me feel more connected and more connected. So I just completely abandoned ship, right? I'm headed one direction, but here I am hearing all of these stories from the patient advocates, and it really has just made me passionate. So 15 years later, I am still at the Asthma and Allergy Foundation of America. I've heard from so many families, and it's just really helped the passion grow and keep going.
Thank you. So Luciana, you mentioned you came into this work because of your daughter's diagnosis. What surprised you as you began your journey through the healthcare system and became a caregiver for your daughter? And what do you wish people at Komodo and more broadly within the life sciences industry understood about the realities of being a caregiver? Especially in the rare disease space. And finally, as our multi-part question, especially with the respect to our work in health data, how do you want us to think about this patient journey and this experience that you've gone through?
So I'll start a little bit with the diagnosis, okay? And I'll just explain a little bit, like briefly, the disease, because it has the name arthritis, but actually arthritis is not the main issue of this disease. It's an autoinflammatory disease, so you have your organs affected. So my daughter, she had liver, spleen, heart, and lungs affected. To be brief, you know the hard case of COVID, the cytokine storm? So the cytokine storm is the MIS, the macrophage activation syndrome, that my daughter had. So this is life-threatening, and at some point she had to use oxygen at home. So this is the kind of the scenery. And she was diagnosed in Switzerland. We were living in Switzerland at that point, and no medication worked for her. We have kind of, let's say, 10 medications that can work, and it didn't work for her. And I went to the US because there was a medication on trial. Actually, the medication was being produced in Switzerland, but the trial wasn't in Switzerland. So I came to the US when I connected with the foundation to try to get a compassionate use, but I was refused. But now I know it was for a good reason, because we had two ways to go. The other way was a bone marrow transplant, but that was an experimental treatment. Less than 100 people in the world did this for systemic juvenile idiopathic arthritis, and that was it. So we found a donor from California. We couldn't donate, and the cells traveled all the way to Switzerland, and she did the transplant. She was 15 years old, and now she's 20, and she's doing great. She doesn't use oxygen anymore. She doesn't take any medication anymore, and she's studying biochemistry. She wants to work with rare diseases in San Diego. So with all this experience, you start to know, well, what can I do now that I'm in a good place? I used to say that when she was sick, I was in a survival mood. The whole family, we were in a survival mood. You just survive. You just live every day, you try to make things good, and then I had the opportunity to get out of that, and not everybody does. So that's really hard. So I had the opportunity to get out, and we are living again. She has a normal life, she's at college. At some point I thought, she won't make it. She won't make it through college. Because the lungs affecting heart, you have to do a transplant of heart and lung. And that's not, transplanting one is hard. Can you imagine transplanting 2 organs? So I came back to the foundation. So once you are out of the disease, you come back again to help other families. And I was really grateful to work with the Komodo data. So one of the projects of the foundation through the CZI grant was to have access to the system, to PRISM. And I was amazed. As I am a science person, and science people, sometimes we are crazy. I was like, wow, I can see a lot of things here. I can do a lot of things. I will have a visibility that we never had. So I started to work with the system, and we got some numbers. But we are a rare disease. So sometimes when you have, let's say, for lung disease in the US, for SJI patients, you only have 275 patients. Okay, so that's Komodo data. And how do you do an average with only 275? They have different ages. They have different treatments. They are affected, and other organs are affected as well. So that's really hard when you get the patient journey to do that. You can see that you have some problems with diagnosis, like with misdiagnosis. Some people, they are having symptoms even 2 years before being diagnosed. So your first symptoms was 2 years ago. And then it takes you 2 years to have a disease code, let's say this way. And then we started to see, okay, so we need to see like more granular. We need really to understand what will happen with every patient. And this is where we are now, right?
Thank you.
Thank you.
And Sanaz, let's go to you. So a major part of your work at AFA involves collaborating with organizations to encourage patient-centered research, which is a term I know we hear quite a bit. Can you tell us a little bit about this initiative, and what does patient-centered research mean to you and your organization? And then what's the value of data and insights to help you drive patient-centered research and also the policy that you lead at AFA.
Yeah, so there's this graphic I like to show when we talk, especially to our industry partners, right? So it's just looking at the research circle, right? Starting with the conception of research all the way through developing the methodology, the protocols, through recruitment, through analysis, dissemination, and then circling back to what's the next piece of research that you're going to do, right? So it's circular. And for the longest time, and this is something I've been really excited about in my last 15 years with AFA, for the longest time, patients were just seen as the research subjects, right? So this whole research circle you've got going on, patients come in as the subjects, what you're studying. But even in the last 10, 15 years, I've seen a real shift to patients being more at the center of this circle, right? So when you're trying to decide what to even study, what outcomes to study, what endpoints are you gonna look for, how you're gonna disseminate, how you're gonna recruit, how you're gonna analyze, how you're gonna drive the next piece, this is really where patient advisors and patient centricity really comes into play. So I've been really excited to see this shift. And so what patient centricity means to our organization is really, just putting it bluntly, looking at patients as more than just the subject, right? You're looking at them as a partner early on if you're trying to decide what you're gonna study, if you're trying to decide what symptoms you wanna alleviate through therapies, what innovative treatments you want to look at, what translational research you want to look at, really having patients at the table early on. So that's really exciting for us. And where the data comes in, obviously, is, in a space like asthma, and I was just sharing with Sharon earlier today, in a space like asthma, your surroundings and your environment play a really big role in your healthcare outcomes, right? Because asthma is impacted by your physical environment, it's impacted by your housing, your school environment, your work environment. All of these play a role, and so really taking the time to look at how all of these different factors and all of the data can play a role into making sure that your asthma outcomes are mediated. So we've used a lot of data around indoor air quality, around outdoor air quality, around medication utilization, really to drive our policy initiatives. We are a national organization. We're based in the Washington, D.C. area, so fortunately or unfortunately, however you want to look at it, we spent a lot of time on the Hill, really advocating for the federal policies, especially around just environment-related policies. So all of this data comes into play because you can't just go in and say, hey, I want to pass this policy, or I want to advocate for this just to advocate for it, right? You really need to have some data to back it up and say, we know that this works, or this doesn't, and this impacts, or this doesn't, and this has to drive the policy discussion.
Thank you. And another follow-up question for you, Sanaz. You've also contributed to the development of AFA's upcoming clinical trial database. How do you see, or how do you hope to see patients leveraging this tool?
So this probably will come as a shock to no one in this room, but a major reason why people don't participate in clinical trials is because they don't know they're happening, right? So you've got an awareness problem. Unless you've got, you're seeing a physician who happens to be an investigator in a clinical trial and can connect you. A lot of times, we've done research in the asthma and allergy community to know that there's a very significant lack of research, I'm sure in your areas as well, and other therapeutic areas. So part of what we're doing is, as a patient advocacy organization, playing that matchmaking role, whether you want to call it matchmaking, being a bridge, whatever the analogy is. The point is that we have the connections with the clinical trials that are happening, and then we can take the extra step to say, here are the ones that you might qualify for. Now, what normally happens in clinical trials, of course, is every clinical trial has its own clinicaltrial.gov page, which is written in a language that most average people can't understand, myself included. Just reading a clinicaltrial.gov site, you've got the inclusion criteria, the exclusion criteria, all of this in a whole nother language that you have to be fluent in to understand. So part of what we're doing is really just translating that into what's the lay language. In our space in particular, I cover asthma, which is not a rare condition by any stretch of the imagination, but we also cover rhinitis, food allergies, COVID, flu, really anything under that comorbidity. And with our clinical trials in particular, there's a lot of rules. If you have asthma and you want to participate in a trial, you can't have, the exclusionary criteria, you can't have eczema, rhinitis, and this makes it really challenging for people to navigate. So part of our role is to A, connect them, be that bridge, and then B, translate. Like, what are you even doing? What are you looking for? What are you studying? What's expected of you? What's the benefit? So that's what we're hoping to do.
Thank you. And Amy, hypothalamic pituitary brain tumors are really poorly understood. They're difficult to treat. So where can we leverage the wealth of healthcare data that's out there to better understand the patient journey of these patients and provide better education, care, and support?
Well, I think with these tumors in particular, and the lion's share of these tumors is craniopharyngioma, which affects children and adults. And one of the biggest problems with this tumor is there's no standard of care and treatment. So wherever you end up being treated, you're at the mercy sort of the neurosurgeon's experience and the protocols of the treating institution. And that is critical in how the rest of your life is going to look when that tumor is treated. So really we're looking at the patient journey and using data to say how many of these patients were diagnosed with this tumor and how many faced all of these other conditions, and how can we rethink the treatment so that we're able to treat it less invasively and create a better quality of life outcome for these patients. These tumors, in the landscape of brain tumors, I learned early on, it's kind of a life or death situation. You either have the tumor and you die from it, or you have the tumor and it's cured. And the in-between area of survival is the part that's just not addressed. And so it's twofold. We can use data to help the patients because advocacy in the aftermath of these tumors is so critical. So we can use data to help the patients find doctors that know what they're up against, that see more of these patients. That's so important because obviously the more the doctor knows, the more they're going to be able to help the patient. And also working with the clinicians to find, to say, this is what this patient looks like 5 or 10 years from now. How can we make that look better?
And Amy, along with the work that your organization does to support patients with hypothalamic pituitary tumors, brain tumors, and getting education and improving access to treatment, your organization also provides support for survivors and really working to improve quality of life. Mm-hmm. What's something that you wish the industry understood about living in the wake of this kind of diagnosis, and what emerging technology could better support disease management?
So, it's interesting. So I come to this as a web designer, developer, user interface designer, so I'm sure some people can relate. I have no healthcare background. When my son was diagnosed with a tumor, the day after he was treated, we were told he had a rare medical condition called diabetes insipidus. And this is not the diabetes that we all are very familiar with, but it's actually the diabetes of salt. His body cannot manage its fluid balance. And this creates a very difficult situation where his blood sodium can either go too high or too low, which can be fatal. When we found out about this condition, we said, well, okay, so how do we test at home? Well, you can't test blood sodium at home, they told us. Then we said, okay, then they said to us, you're gonna have to measure his body fluids ins and outs, so how much he drinks and how much he pees. We're gonna need you to call that in every day and let the clinician on call know. Then they're gonna calculate it and tell you how much he's gonna need to drink and how much medication he's gonna take. Well, this to us was just like, are you, seriously? My husband and I looked at each other and we're like, what? And that is the first moment that I realized what a rare disease was. There's just no tools. And so in the first year of managing this, he was in and out of the hospital. We lived 2 hours from the hospital. We took a lot of helicopter rides, more than I care to remember. And so we set out to develop an app because we needed a better way to calculate his ins and outs, to do the calculations on the fly, and to allow his clinician to log into the app and see that without having to have a phone call, without it being, just to kind of improve the communication. And that's where I saw there's so many technology gaps in healthcare that could improve communication between the patients and caregivers and clinicians to make this process, first of all, to be more proactive in managing the care, and to just, we have these tools. It just didn't seem like they were being used as much in healthcare as in pretty much any other application. So I think that, I see a lot of opportunity, and hopefully our foundation is working on actually releasing that app to our patient community, along with building a medical device to test blood sodium at home. So these are all places where technology can make a huge difference.
Thank you. Luciana, you live in Brazil, but your daughter was diagnosed in Switzerland, and you came to the US to find treatment. What are the biggest differences you see regionally around access to treatments, clinical trial participation, or the patient experience more broadly?
So, we were living in Switzerland when she was diagnosed. So we left Brazil for work, and at that point we were living in Switzerland, so that's where she was diagnosed. And I felt very lucky, and I'm really grateful that I was there, and that we had a medical team that, okay, let's do that, because it was not normal to do a bone marrow transplant. Regarding clinical trials and treatments, so, first treatments. We were there just 6 months, so different culture, different health system. If you move from Brazil to the US to Europe, even inside Europe, because Switzerland is one of the countries that you have private insurance, health insurance, like every people needs to have an insurance. So it's a kind of a different perspective of other countries there. You have to navigate, you have to adapt. So I had to adapt and to understand how it worked. And then I came to the US because the trial was here. So it was in Europe, but my connections with the foundation, the trial was here, so I came here. When I see Europe and the US, you have a lot of access to medications, really much more into clinical trials than, let's say, Brazil. So Brazil has to adapt to the medications that you have. And this is not easy to say when you are a patient, that let's say I was living, if I were in Brazil, so my daughter wouldn't have access to at least 4 or 5 medications out of 10. So that's hard for a parent to hear. But even in the US and Europe, when you don't have, let's say, a protocol to treat. You just try the medication, see if it works, and if it works, then it's okay. If it doesn't, then you try another one. And it's not like Europe is right and US is wrong, or US is right and Europe is wrong. The doctors, the physicians, they will do what they think is the best option for you. And we are talking about medications in the pipeline. We are talking medications that are on the market, like, let's say, for 2 years or for 3 years. So you don't know the side effects that we'll have for these kids. And let's say, if they use this medication for 10 years, because we are talking about immunosuppressants that are really severe, that will put your immune system really, really down. So it's kind of, let's try. So this is the word, let's try. And regarding Brazil, our health system, the public one, for rare diseases, it's pretty good. Even a lot of people that they do have private insurance, and that's 25% of the population of Brazil, if you have a rare disease, you will go to the public system, because that's where you will get care. The problem is, until the diagnosis, to get a diagnosis, because sometimes it's really hard just to be seen by a geneticist or something like that. So sometimes it will be 2 years. So they are starting to do the screening on the newborns. So that is getting better. And I'm really grateful to see that there are a lot of great people working in this system in Brazil to make it better, for the screening to be better.
Thank you. And a question for everyone here, and we'll start with you, Amy, and then we'll go to Luciana and Sanaz. If you had to name the biggest challenge facing your patient community, what would you say? What are some of the data insights that would help you as an organization to address that challenge?
I think the biggest challenge, as I talked about earlier, is that there's no standard care in treatment for the tumor. So that sets off a lot of struggle because a family with a child that's newly diagnosed that may have time before they treat the tumor will tend to go for other opinions and get completely different options. And then it becomes a burden on the family because you're deciding the fate of your child, essentially, as you decide which treatment you're gonna go with. And then additionally, then it's the lack of ongoing support for the families. Many struggle with conditions, one of which is hypothalamic obesity. So that is where the brain has lost the ability, the hypothalamus controls your whole, it's the master control of your body. So it's your hunger, your thirst, your metabolism. When that goes, the body puts on weight and it's not mitigated with diet or exercise. There's no treatment for this, and it can be one of the most devastating side effects because the children and adults are also hungry all the time. And it's really hard to find any doctors that have any knowledge of this condition. And so being able to get the data to see what doctors treat patients with craniopharyngioma and obesity gives us some insights in knowing that this doctor might have a little more knowledge about this condition and so potentially could be able to support the patients. Because right now, it's really hard to find physicians that have any awareness or understanding or knowledge about the comorbidities of these tumors. And the reality is there's little known about the brain. There really is not a lot we've been told there's not a lot known about the brain. So a lot of times it's just, being able to find that one person that has a passion about this that can treat these patients and at least give more support. And so the data allows us to see who those physicians are.
Thank you. And same question, Luciana. Okay. If you had to name the biggest challenge facing your patient community, what would you say? And what are the insights, the data insights that can help your organization?
Okay. I'll name 3, okay? Not only one. The first one is the treatment itself. It is a real challenge because the medications are really strong. So we are talking about medications that will make your immune system be really weak because our patients, the problem is that their immune system is too strong. Then you have to make it weak. But this, when you do for 1 year, it's okay. For 2, maybe okay. But for 10 years, taking one medication like this, or 2 or 3 sometimes, so this is really a challenge. So I would say effective treatment that could put the disease into remission. The other thing is timing. So the time of the health system, like I will put everyone here, is different from the time of the patient. So if I'm sick, I need a medication now. I don't need a medication in 5 years when the clinical trial will give me. I do understand that we need to test, I understand, but it's difficult when your life is depending on a medication that you know it's there and you don't have access to that. So for a patient, it's really difficult to see that. So, and I think that data can help in decreasing this difference in timing, the health system and the patient wanting a new medication or compassionate use. So, because if you understand better what is going on, things will move faster. And the other thing is awareness. We could see with the system that the patients were taking 2 years to be diagnosed. So if you tell rheumatologists, listen, there are a lot of patients of SJIA, they are presenting symptoms even 2 years before. So let's see here, what are the main symptoms for this specific disease? Then you educate the area, because we are talking about a rare disease, so it's not a thing that will come to you like every day. There is one doctor, and he was like, it was great to hear this from a physician, a senior physician. He said, I'm a specialist of this disease because I saw in my whole career 4 patients, and I treated 2. So he considered himself an expert, because sometimes you don't even see. So when you have this visibility with the system, with data, so you can start connecting everything, and things will move faster.
Thank you. And Sanaz, same to you. Biggest challenges facing your patient community and how data insights can help your organization address these challenges.
Yeah, so I'm going to do a rapid fire. I'm also going to pick 3. Starting with access. Again, asthma and allergy is not a rare condition, but it almost feels like a cop-out answer, but I will say access to all of the innovative therapies that are out there, access to the specialists who are needed to really treat a chronic condition like this, that's really lacking. It's hard to have a conversation around advocacy without really talking about access to everything that's out there. The second one, and I touched on this earlier, but it's disparities. So asthma tends to be a poster child for racial and ethnic disparities. Because asthma is, again, so impacted by your external environment, it's so intrinsically tied to economics, to housing, to employment. All of this turns into a web of like social determinants. And so asthma, unfortunately, has over the years just been the very obvious disease that's covered for health disparities. The good news there, if you can call it good news, is that there's more attention being brought to asthma disparities. So at least we're kind of working towards reducing those disparities now. And then the third one I'll mention, just to touch on your question about data insights, is in some cases there's data being used that's not the right data to make decisions. And the example I'll give is with all of this innovation happening, especially in the respiratory and immunology space, there are organizations who are saying, you know, well, you have to fail first on this, this, and this before you can have access to this, right? And they're not using the right data to say, if you just jump to this, if you jump to the new treatments, new therapies, new programs, interventions, whatever it may be, if you just jump to that, you're reducing exacerbations, you're reducing hospitalizations, you're reducing asthma-related deaths. They're not using the right data to establish, like, you can jump ahead, maybe go on something that's more expensive, but at the same time, it's reducing all the costs on the way. So I would say that's one barrier, is just kind of using the wrong data. We have access to all this great data. Let's look at, you know, who's having an over-reliance on emergency care for asthma, right? Instead of going to a specialist routinely, who's over-relying on the hospitals. There's all this great data we can use, and I think we're not necessarily using it to the best that we can.
And a follow-up, Sanaz, for you. So now that you've used Komodo data and PRISM to address some of these disparities in care, have you seen that start to move the needle in the work that you're doing?
Yeah, so actually we've been using Komodo data for a few different things. Every year we publish different reports that identify trends and needs, right? So that's pretty standard. You want to know, with very limited resources that patient advocacy organizations have, you've got very few dollars and very few staff, where can you spend them most effectively? So your data really comes into play, at least for us, to identify where the highest needs are and where the trends are. And so, yeah, you guys have helped identify, especially in our health equity work, like where are we focusing our health equity work, for example? Where are the areas that have the highest emergency needs or emergency utilization, and where can we employ those dollars? And so we've been doing evaluations, we have seen a reduction in use of oral steroids, for example, that are considered emergency medications. We've seen a reduction in those pilot areas in use of hospitalization, urgent care visits, and things like that.
Oh, thank you. Mm-hmm. And one more question to close, and we'll go through each of you with the same question again. What makes you hopeful for the future of healthcare? Where do you see the seeds being sown for better outcomes for the next generation of patients in your respective communities? And Luciana, we'll go ahead and start with you.
Okay. So I think that science is moving faster now. Science and technology, not only in the healthcare, but science is moving faster. And I love this. We have seen, like telemedicine now is a reality that we thought that maybe some years ago was not going to be. Decentralized clinical trials as well. So this can help a lot the rare disease community because sometimes you have just one patient here, one patient there, and they don't have to travel to the centers. And also specialized centers are also being, a lot of people are talking about that in different countries. So these patients can be treated in specialized centers for rare diseases. So if science is moving fast and we can get better solutions, I think that people should have access to medications in every country. So then this is my dream, because yeah, we have technology and we have other things, so why not having the equality?
Thank you. And Sanaz, what makes you hopeful for the future of healthcare and the next generation of patients with allergy and asthma?
Yeah, I'll tie it back to the three points I had in what makes me kind of the challenges. So around access, I will mention, we haven't talked about this yet, but some of the barriers that have been kind of reduced with the pandemic, so things like easier access to telemedicine, Medicaid auto renewals, things like that. I'm hoping, fingers crossed, if we can keep some of these reduced barriers going through, past the pandemic, it would really eliminate some of the access issues. I mean, it's not going to solve every access issue, obviously, but it's a step in the right direction. So we're really, really pushing for that over on the Hill and in the States. The second point I made was around disparities. I will reiterate that at least now in asthma specifically, there has been a more social kind of awareness of the health inequities and working towards those. And then the third one was around just the use of data. And I will say I do feel encouraged about our access to the Komodo data set and even to just data in general about using that to drive our programs. When I first started at AFA, it almost felt, and I wouldn't repeat this outside of this room, but it almost felt like we were just building programs to build programs. And now it's really using the data to drive, like, what are we building? Let's be intentional. Let's make sure it's serving a need. And let's make sure we can evaluate and collect the outcomes to prove that it works.
Thank you. Mm-hmm. And Amy, to close, what makes you hopeful for the future of healthcare, and what do you see being sown, the seeds being sown for the patients in your community for the future?
Yeah, I think from my perspective, the tools to empower us to become better advocates, I've seen those evolve so much over the years, and I also see the recognition of patient advocacy organizations grow. And the realization of the importance of that. Because I think at the end of the day, and this is in any healthcare situation, we are best successful if we are our own best advocates. And I think that, the healthcare industry is hard to change, but to be able to advocate for ourselves and have access to information and data that allows us to do that better gives us a better outcome. And us being able to also provide that access to underserved communities and underserved patient families that may not have the resources is just an amazing thing, because at the end of the day, I just feel like being able to advocate for my son has given him a better outcome. It hasn't fixed the problem, but it at least allows for him to have a better future. And I hope that as we build our advocacy group for our patient community, that allows other families and other patients and children to have brighter futures. So I think the tools that are growing and becoming more available through PRISM, for example, that allow us to see the doctors that are treating these patients more frequently, just gives us a chance to be such better advocates, and that brightens our futures.
Thank you. So on behalf of all of our dragons here today, I would like to wholeheartedly thank you for coming out, for sharing your stories, for sharing all the work that you're doing at your organizations, for your patient communities. There's a lot of work to be done, I know. I know you feel it, and we're only just scratching the surface of what's possible. So we're incredibly grateful for you and for the insights that you shared today, and just want to thank you so much for your time and for joining us. So thank you so much.
Thank you. Thank you.